Okay, I want to talk about the joint by joint approach. Many of you are familiar with this idea. It's kind of a physical therapy theory. It's pretty useful. If you did some TPI trainings, you're probably very familiar with it. It is a great starting place, but it's also, I wouldn't say flawed, but there's a lot more that goes into it, right? So again, great starting place. The idea in general, if you start from the foot and work our way up, is in general, certain joints create or have access to a specific type of mobility or stability. So they're either more geared towards stability or more geared towards mobility. The foot itself, more geared towards being stable, rigid. The ankle, mobile. The knee, stable. Hip, mobile. Low back, stable. T-spine, mobile. Lower cervical, more stable. Upper cervical, more mobile. And then you have the scapulothoracic joint and the shoulder joint. So scapulothoracic being a little bit more stable. Shoulder glenohumeral joint, more mobile. Stable at the elbow, then wrist, mobile, right? That being said, every joint has access to range of motion in every plane. There is the subtle motion in every single plane at every single joint. So the theory in general does a good job of creating a general emphasis on where should we be working more towards stability and where should we be working more towards mobility if they're lacking. But overall, we're going to need to work on mobility or stability at any given joint, depending on the exam. So how does the joint by joint approach help us? How does it kind of relate to our last video? And what does it have to do with regional interdependence? Now, regional interdependence is the idea that you can have issues at one spot creating pain or other issues at another spot. The idea that we might be all familiar with is, may say, like a thoracic spine restriction or a loss of mobility in the T-spine, creating shoulder problems. So the idea there is if I can't get into full thoracic extension and I'm doing work overhead, that instead I'm going to have to get into more, so if I can't do this, more shoulder flexion to do work from here. Now I'm not working in a, what we call like an optimized position, and we can create damage and injury to that shoulder joint. So a T-spine restriction is the thing causing shoulder pain. I can work on the shoulder pain all day long, create stability, strength, mobility back into the shoulder, work on the damaged tissue and the healing times of that tissue and load it up correctly and get that feeling better and healthy again. But the moment I start working through here again, if I haven't fixed this problem here, this is going to come back. So in the golf swing, joint by joint approach, we can use these theories to keep us honest. The idea is to make sure that we are assessing everything. That is the extent of the joint by joint approach. For you as coaches and teachers on the range, it really helps you hone in on making sure that these specific areas are at least giving you the minimums that you want. But the issue there is that you might not look at a lumbar spine for mobility because it's a stable joint, not supposed to get much motion from there anyways. In terms of low back pain, hips, T-spine, we talked about it. We need mobility through there. It is quite common that restrictions in these areas, which are supposed to be mobile joints, will be the root cause, asymptomatic root causes in low back pain. Their lack of mobility is creating the pain that low back has to work extra hard. We know, hey, it's a stable joint, so when it has to move more, it doesn't like it. That's true, but it is also the case that a stiff low back who has restrictions in that lumbar facets will also generate pain in the low back. So we do need mobility at the lumbar spine, classified as a stable joint or a stable section of the spine. So we can't get bogged down too much in that joint by joint approach. I think in your case, it does a great job of helping you just do a quick look and see, are these joints generally showing what they generally should be doing or not? But in here, we take things just a lot further. I want to give you kind of a case study or idea of the regional interdependence and how it relates to the golf swing. So for instance, let's talk about knee pain. We talked about low back pain. Let's talk about knee pain and regional interdependence. We'll use that hip. Everything comes down to the hip, pelvis, and T-spine in the golf swing for the most part. It's at least involved in everything. They're never the only things though. But if we have knee pain and say the lead side leg for a golfer, And all we're working on is rotation through, or sorry, loading up this knee joint, being strong in this knee joint, or say even just, hey, just flare that foot a little bit, take so much pressure off, you'll be fine. We know we don't want to do that. It could be something in the meantime as we continue to work and improve other things. What we need is a full exam. Where are we missing things that we need? Now, a joint by joint approach might say, hey, do we have stability of the foot? Are we able to pronate, supinate? Do we have mobility at the ankle? Can we dorsiflex and plantar flex? Knee, well, supposed to be stable. Hip, do we have mobility here? Low back, well, supposed to be stable. We have T-spine, yada, yada. If we did that, we might miss that we have full thoracic rotation. Actually, maybe this hip is pretty good. So regional interdependence is saying, well, these other spots are actually doing pretty good. Joint by joint approach is saying that's all we need to do. That'd be incorrect. This knee joint, which is a stable joint, also has access to not just flexion and extension and nothing else, but there is internal external rotation that happens at this joint. I'll show you a video of a patient with knee pain on one side who is lacking in internal external rotation at this knee. So a stable joint, well, we're doing mobility testing here, and it can be quite significant, the results of this mobility testing. So I'll show you what that looks like. We want to keep the knee stable from here, toe in, toe out. So without this knee or hip coming along for the ride, what is this foot able to do? We start neutral. I'm going to start with external rotation. Good. At least 20 degrees. Usually they have more towards 30 or 40. Usually not a problem. Internal rotation of this knee, oftentimes an issue. So this is coming from the tibia on the femur, as well as that ankle there. So what do we see? Internal rotation, we want at least 20 degrees. I don't have much of a problem there. Some people will not have access to much internal rotation. It's quite common. So every time we're coming through and we're trying to rotate onto this knee and we need access to that mobility, we run out of it almost immediately. And what that does is it creates torque in all the ligaments and soft tissues through that knee joint, even the meniscus. Now we have knee pain and injury. We skip this joint because we know it's supposed to be stable. We can load it up. It's got flexion, it's got extension, but otherwise it's good, right? No. We need to do mobility testing still at this stable joint. And then another idea with just regional interdependence is with this here, this hip also takes a lot of load off this knee if we have full access to, in this case again, internal rotation on this lead side hip, right? So as we come down, say I have 10 degrees of internal rotation. Not uncommon for me to find golfers with 10 degrees of internal rotation with some pain or with some chronic or consistent swing issues. As we come through, they lose access here. Okay, where are we going to get our rotation from? Where are we going to put all this force into? Knee gets torqued, ankle gets torqued, this low back gets torqued. Now we want motion from that low back, but when we run out of it here early, it starts putting more into that low back, into that knee. So that's regional interdependence at work. This hip problem, asymptomatic, no pain here, it's a mobility issue, creating knee pain, knee injury, or it could be low back, it could be whatever, right? But in this case of knee pain, there's a lot more testing and assessment we're going to do, but two things we're going to work on is knee mobility, especially for internal rotation, and then with hip mobility as well. Then from there, we integrate that into that swing, we pull their foot back into line, and then we teach them how to use that, that mobility in a closed chain position, create strength into this hip. It's going to be especially important. We can't just work on mobility here. We have to create stability, and then, again, integrating that into the swing. So, again, if you're dealing with someone with knee pain or any pain and you're considering the joint by joint approach, again, remember, there's a lot more details. It's a great starting place. There's always further that we can go. So if it's sticking around, you're trying some things, some exercises or some stretching, it's quite not doing the trick, either in terms of their performance or in terms of their pain, then bring them in for a full assessment and we'll get to the bottom of it. Okay, so thanks for listening.